Good evening from Frankfurt. Welcome to session 6 of day 1 of Rhythm Interventions Online 2025. I am Julian Chun from Frankfurt, and this session is called Modern LAA Management with PFA, Integrated Eyes, Advanced Mapping Platforms, and Next Generation LAA Closure Systems. For this session, we have a recorded case from the operator Devi Nair, who else, who joins us. And we welcome back to the panel Andrea Sarkozy from Brussels. And we are also joined by Mansour Razminia from Chicago, United States. So it is a really fascinating topic. So without any further delay, I will hand over to Devi to take us through your case.
Thank you for coming back with this system. I'm actually going to be presenting on a new integrated ICE technology and how it integrates with mapping, and then kind of delve into the next generation LA closure that's coming in the future. If you can advance the slide. These are my disclosures. Next slide, please. So just as a quick overview, if you could put the slides back. So we'll be showing the ViewFlex ICE catheter. The ViewFlex ICE catheter is a catheter that is the new ICE catheter that will be integrated with the Abbott mapping system or the NSIDEX system. It has a sensor-enabled little sensor at the end that's going to show up on the NSIDEX system. It's still the same 9 French catheter. It has the quad directional deflection that we're used to, and also the same linear array transducer that has the same image quality that we're used to with the ViewFlex system. Of course, it still has the built-in cable and all the other features that comes with the ViewFlex ICE system. The beauty of an integrated ICE solution is that you can visualize the tip of the ICE catheter within the NSIDEX system. You can visualize the tip of the ablation catheter within the live ICE image. So you have both ways connection. You can have ICE markers, so you can delineate these structures within ICE and transfer those markers onto the NSIDE module. So and then built in these auto contours with the NSIDE system. Now, the other feature that I'll showcase is the contact index module. This is a module within the NSIDEX system that allows for dynamic impedance measurements. So you can, for example, with the pentaspline catheter, it will look at the local impedance changes on the local splines and show you, give you an idea of the contact assessment. And the NSIDE system has historically used impedance-based tracking and change in impedance to track contact, and this is something that's been leveraged onto the PFA platforms as well. So the way the system displays it, it looks at a delta for the impedance drop, and you can assign the delta depending on where you are in the left atrium. And say if I assign the delta for say 10 or 12, once I get to that delta in drop in impedance, the spline turns blue. And so it's a nice visual interpretation and easy physician interface as you are moving the catheter around to see if there is contact. And as I said, you can also see each of these splines independently. That allows for dynamic understanding of the spline position, lets you understand any kind of crowding or inversion of the splines, etc., as you're moving around. One of the other configurations that you have with this new mapping solution is the tripole configuration. So as you all know, with the FARAWAVE system, you're just actually looking at one of the electrodes. But now with the tripole configuration, it allows you to see at least most of those electrodes. So it gives you a little better near-field EGM resolution along each spline. So lets you understand what that near field and far field signals are in a little better way. So let me introduce you to the patient. This is a patient with persistent atrial fibrillation. Came in actually for repeat for PVI and potentially a PVI plus strategy due to her persistent AF nature. And if you could play the first video for me, that'd be great. So I'll walk you through the case of how we're using the integrated ICE here. So I always get my access with ultrasound. You can see we do pre-closure. We tend to send our patients home the same day. So this is one of those things. Now some of this video is sped up, so just to kind of keep the time constraint. So you can see what I'm doing here is I'm actually marking the CTI. So those yellow dots that you're seeing on the Insight map, that's on the bottom right, is where we mark the CTI. And here, I've done I'm looking at the LA from the right atrium, and we're creating this ICE model. So as I'm moving that ICE catheter around, it automatically contours and creates the shell. So once it's created the LA shell, you can see we're doing a transeptal. This is almost a mid transeptal. I usually take my ICE catheter into the left atrium. And you can see I've created the transeptal track on my 3D map, and I move my ICE catheter into the left atrium. Once I get into the left atrium, on the bottom right, you can see we'll create we'll kind of redefine our shell. I'm doing a high density map here since it's a more persistent case. I wanted to understand the substrate in this case. And once we have a better understanding of the substrate, we'll move on to the pentaspline catheter. So here you can see we're moving in with the catheter. And one of the features, you can see that the splines are turning blue when you have contact. But I'm also looking at ICE for assessment of contact. So on the bottom there, you can see how we're looking at ICE, looking at contact of the splines with the, within the ICE catheter, but also looking on the mapping system to see if the color changes. And each of the splines, as you have that delta drop. So for the veins, I usually use about 12% drop, and for the posterior wall, I use about 8 to 10%. The one thing you see on the map on the bottom right is the integration of ICE within the map, and you can see just one map, and you can enlarge your map and just look at on ICE and the map in one single view. So this is a left inferior pulmonary vein in the flower configuration, and you can clearly see how the petals are in good contact. Here you can see the wire going into the right superior pulmonary vein. One of the other things that is new, this is a newer software that is not yet available, is you can see the blue and white lesion tags that the system is dropping as we're delivering the lesions. So the blue and white lesion tags are based on that delta impedance drop that you got. So before, you would just do a projection overlay map with the Insight system. Even though you can assess the blue, contact with the splines and the delta drop, you couldn't really drop the tags that way. With the new software, now the tags are going to be coded according to your delta impedance drop as well. So really kind of lets you do a very efficient kind of workflow, keeping track of your lesions as you're going along. So here you can see we're kind of getting into the right inferior there. You can clearly see on the ICE image on the bottom left how we have good contact with the right inferior pulmonary vein in a nice antral manner. And then you'll see that now I've moved on to the posterior wall. In this case, because this patient had had multiple cardioversions and a pretty enlarged left atrium, we decided to debulk the atrium with a PVI and posterior wall approach. You can see again, looking at ICE for assessment of contact, but also looking at the splines on the map to make sure that we have adequate contact. And you can see the lesion tags, you can see the shadows, you can choose to show the shadows or just the lesion tags and then kind of move from there. If you could just show the next video. I want to show us a different workflow for a patient that is more of a redo patient. In the redo population, here you can see we're creating that shell again. On the bottom right, you can see the auto contours that the system is creating. Now, this is a redo patient that has a watchman that's already implanted, and you can see on the bottom left image, the watchman in place. And what we do there is I have my mapper kind of draw the outline of the watchman device or the LA closure device, and the pink tags on the map are the tags for the LA closure device there. And here again, you'll see that I'll do my transeptal, and I'll actually get into the left atrium with the ice and redefine that LA closure device on the map. And the advantage of being able to do these calipers or do these tags on the map is when you are, say, ablating within the left atrium with these with the PFA catheter, you now can see how that PFA catheter is in proximity to the LA closure device. So giving you an idea of how well you can stay away. So you don't really have to use fluoroscopy or have to rotate the eyes too much to see it. So the advantage being that you can just look at the map and have an idea of where the system where the system is showing the LA closure system. And here you can see I'm ablating along the left superior pulmonary vein. And as I'm getting close to that LA closure device, you can clearly see I'm doing the mitral isthmus and making sure that I'm staying away from the closure device, preventing any I would say, confounding between the LA closure device and the PFA system. I want to quickly go into the next slide, just showing the upcoming or the next generation LA closure device. So if you could just move on to the slide deck. So this is introducing the Amulet 360 device. This is the next generation of the Amulet device that is currently being evaluated in the Veritas study, which is a prospective study, single-arm study looking at 475 patients, looking at the Amulet 360 device. And the difference of this device is you can see on the top right, the current generation device is a more, I would say, device that has a distal tip, as well as it's a little more stiff device, and it's the newer device is a more conformable device. And if you could please show the video, the next video of the Amulet 360 implant. So this is a quick video of the case. You can see that we do pre-planning. You can see the anatomy here. And what the study did require us to do pre-imaging to make sure that the patients were candidates. This is FEOP simulation showing how a current generation Amulet would fit in. The study was performed under TE guidance per protocol, so you can see what the anatomy looks like for this. This is 3D TE that we're doing. You can see the angiogram there. That loop is about 24 millimeter loop. That was across wire has a 24 millimeter loop. And you can see the anatomy. And because the device is a little more softer and more compressible, it also has a different set of anchors. The anchors are much shorter than the current generation Amulet device, and has two sets of anchors. The anchors are about 0.5 millimeters once it's outside into the LAA tissue. You can see as I'm entering into the left atrial appendage, because it's a more conformable device, we choose to use a little bigger size and fill the appendage. So you can see as we're going into the appendage, you can see there's no distal puck anymore. It's an inverted distal puck, so much softer ball that allows for a safe entry into the appendage, and then a very, very slow deployment of the device, allowing this lobe to kind of open up within the appendage and conform to the shape of the appendage. And that one of the things that we've seen as a difference between the current generation and the next generation, or this new generation, is that unlike the current generation where the LAA kind of has to conform to the device because of how stiff it is, this new generation is so conformable that it kind of conforms to the LAA. And I think that is something that we have to see how the results transform to, whether we see any improved safety markers with that. So here you can see the lobe has been deployed. I like to do an angiogram to make sure that the lobe is in an appropriate position. You can see on the TE that the lobe is in a good position, but then we'll actually, once we've ascertained that the lobe is past the circumflex and is in a good position, we'll deploy the disc. Again, the Amulet 360 is also a lobe and disc device, just like the current device, allowing for a dual seal. And I think the hope is that with the dual seal, we will still be able to get that adequate closure that we got with the Amulet device, but have that improved safety margin, hopefully with with this more conformable lobe and the smaller set of anchors. And here you can see the disc being deployed into the orifice of the appendage. And again, as I said, you can see how well that lobe is conformed within the appendage. Very different than the current generation device. Again, looking for a very antral isolation. Julian, as the video plays, I'll give it back to you to take any questions, and we'll kind of keep the discussion going.
Wonderful, Devi. Thank you very, very much. What an impressive and elegant LA closure, which were able to observe, but also very interesting how elegantly you used the combination of ICE and the latest generation, also in combination with latest PFA ablation. Let me just start maybe the discussion by asking Andrea. Our European perspective on ICE has been traditionally a little different compared to our colleagues in the United States. So now we have, of course, seen how Devi used ICE 3D mapping for the LAA procedure CT scans. Where do you see the role of imaging for ablation, but also later on for also LAA closure, given our, let's say, European perspective on that?
Thank you, Julian, for the excellent, easy question. So I was just thinking the same as I was watching the second case, using the first, the ICE and the HD grid, and then so elegant, nice procedure. Finally, once the HD grid has shown us the target region in this flutter, if I've seen it right, it was a flutter. Then the final lesion there with the Farapos with the catheter, and I was just thinking that from a European perspective, for us this is not possible to use this this many. Given the reimbursement issues and resources, this amazing catheters for us all together in one procedure would be quite difficult. And I was just thinking to ask Debbie about this, that so is it possible that when we see, for example, the lesion text and we have a good sense of contact based on the impedance drop, do you think we could in Europe, this could replace the ICE catheter? What's your feeling on the first procedures? Is there a good correlation? Is this really reliable for us to know if we have at the bruise sites the contact was sufficient and we delivered sufficient good lesions with sufficient good contact?
That's a great question, Andrea. I think one of the things when I first started using it was that I was still focused very much on ICE, like I was used to assess contact. But the more and more I started seeing the one-to-one relationship of, when I saw a blue spline, it was almost always in contact. I think that kind of has pushed me to kind of focusing more just on the map. I still use ICE, obviously, because I have access to it, number one. Number two, I like the images, and it's almost a safety net for me to have ICE. But I will say that I'm more dependent on the map and the lesion tags now. I will say that I have cut back on the number of lesions because of the blue tags, because you're not just doing overlap with just the catheter shadows, which is how I used to do them, is just have enough overlap with shadows. But now I'm actually more focused on the lesion tags. So I think for me, as I was traversing through, one of the discussions that has always come up is, okay, this technology of having this contact assessment is going to be extremely useful for people who don't use ICE. And so for Europe, I think that's one of the advantages. And for us to be able to see that one-on-one association, I think it should give you guys confidence that you could potentially use the catheter with this software without having to worry about contact and still not have to use as much fluoro. Because I think today to assess contact, you have to use fluoro. And maybe this is an opportunity now to maybe cut down the fluoroscopy use and actually just use the mapping system.
Yeah, thank you. That was a very, very good argument. And also maybe by reducing or delivering the correct application at the correct size with proper contact. Maybe Dr. Razminia, What are your thoughts on what is your experience on relying assessing the proper contact, and what are your general thoughts about contact per se in the area of course, pulse field ablation? I'm sorry, I cannot hear you.
I'm so sorry. All right. Thank you so much for the invite, Devi.
Now, perfect. Yeah.
As always, it was a great case. And I saw that when you were ablating in the roof, that ATAC went to sinus rhythm. That was fun to see. Basically, I have a special relationship with ice, using it for over 2 decades. I always say, even if a patient comes for a haircut to the hospital, I use ice. So I just have that something that I am so dependent on ice. But ever since this new version that we are using, and we would be able to see the contact, which the screen, the spline start becoming blue, I have been able to really correlate them with the ice catheter, and they are amazing. They really, that correlation, when I see that I'm advancing the catheter spline in the posterior wall, and I see on ice that I have a oblique sinus, and oblique sinus obliterates, which means I'm having a great contact and push, and I see that the impedance drop more and the spline become blue. That correlation is amazing. And as we discussed, unfortunately, that is very sad just in Europe, because of the reimbursement availability of ICE is not as good, especially given the fact that we can use it if you're going to place a left atrial appendage closure, or with the new versions of PFA systems that you can do them under conscious sedation. So you don't need to put a TEE to place a TEE to probably, because I assume that majority of places are going to do under general anesthesia. So using ICE and those kind of PFA system you would be able to do the entire procedure under conscious sedation or max sedation. But yeah, the system is fantastic. In US, we use ICE for everything. We do re-sterilize ICE. So the price is going to be much cheaper. So that is always something that if US can do it, why not other countries can do, being able to reduce the price. I always have the mentality of, I say Costco mentality. Costco mentality I have is that reduce the price, sell it in bulk. You can sell 5 Rolls-Royce, but you can sell 500,000 Lexus. So bring the price down just to try to, okay, those are something for those, of course, for the industry. But if we cannot do that, certainly by being able to talk to the, health department, to the appropriate, departments, that to be able to, get it re-sterilized, and being able to, I have seen in some of the, countries that this ice has been used 25 times for one single. So not that I'm just saying that this needs to be done, but I mean that maybe 1 or 2 twice you would be able to re-sterilize, you would be able to bring the price down.
Yeah, I thank you very much. I think this is a very important comment, and thank you for all the negotiation tips for us in Europe. We will definitely listen and see where we can end up in the next year. But let's switch gears and come back to the LAA one more time, Devi. You have nicely, and I think you said the device, the new AMLET NG or the 360, it conforms to the anatomy. And in your experience, how often, or do you see, let's say, a lower need for device missizing, or also a higher rate of 100% closure of LAA using the dual, let's say, components system? What are your personal initial experience on the device?
I will say that, it's very limited experience because it's just part of the ID trial. We probably about 40 cases. With that, I would say, at least for my cases, acute closure was pretty good. The beauty of a dual seal system is that you have the lobe that can give you the primary closure, and you can always get the disc to get that secondary closure on top of the ridge. And as long as the disc stays above the ridge, you have a really nice closure. You don't have to worry about those little crevices on the ridge or the little lobes along the mitral isthmus, etc. Now, one thing that I would say is, one of the challenges with the current generation for me was, I did not like to oversize the current generation because of how stiff the lobe is and because how long the anchors are and the concern for collateral damage and pericardial effusion, etc. And so then when you don't oversize, sometimes you cannot get that disc above the ridge, and then you lose the benefit of the dual closure. Now, with the current this new generation, what I noticed is that the lobe is so conformable, so I felt very comfortable upsizing if I had to. So I was not just sizing to the appendage and the lobe. I was actually sizing to the disc to get that very beautiful closure that you see with the dual closure systems. So that is something that I'm looking forward to. And again, we have to see the results. I mean, we just finished enrollment. We're hoping to present our 45-day data at AF Symposium, and that would show acute safety as well as 45-day seal rate. So we're hoping to see what that would show, and more to come, right? So at least the acute implant success rates were good, but we'll wait and see what the results show.
Yeah, wonderful. Thank you very, very much. I think that was a fantastic session. And unfortunately, it's time for me to close this session. And I will, basically have to thank the great panelists. And of course, I need to thank Devi for your great case and your very elegant case which you presented. Again, Andrea and Mansour, thank you very much. And out there to the audience, there's still much more to come on day one. We will be back in just 1 minute.
Thank you.
Thank you, Julian.